My name is Kostas Patris. I'm an anesthetist. And in the next few minutes, I'm going to talk about the situation that is the pharmacological management of a situation that is called post-operative low cardiac output syndrome. Unless you are part of the unless you are close to the perioperative situation, you may never heard of this situation. But actually, it is a situation that is very frequent. It has been described since 1970s that about 1 in 4 patients who undergo a cardiac operation suffer a few hours later a drop in the cardiac index of less than 2 liters per minute per square meter within 6 to 18 hours after cardiac surgery. It may also occur secondary to acute myocarditis and septic shock. And you see the graphs from the original paper that shows that there is a significant drop in the cardiac output a few hours after the operation. Now, what we think is the reason for that is that there is an imbalance between the systemic oxygen delivery and which is called DO2, and the oxygen consumption, which is VO2. And our work as anesthetists or intensivists is try to maintain the oxygen delivery and minimize the oxygen consumption. Probably this is the best thing that we can do when we treat children who have undergone surgery for this congenital heart disease. So I will remind you a few things from the physiology from medical school. We know that there is oxygen delivery when it's high enough to exceed the oxygen consumption. We come to a point when we decrease the oxygen delivery, that it's the critical DO2, that when down below that point, the consumption of oxygen has to decrease as well, because cannot meet the demands of the oxygen delivery. And that happens on the red line, that is the normal situation. If for some reason the oxygen consumption is increased, then we have the green line that moves a little bit up and to the right. And we have the oxygen extraction ratio, which is the ability of tissues to take oxygen from the blood. And it's around 30% in normal cases, but the myocardial cells have the ability to increase, if that's necessary, up to about 50%. That's probably the only cells in the body who can do that. The neural cells cannot do that, the brain cells. And this comes to a critical point as well, where no more oxygen extraction can happen from the tissues. So which are the factors that are responsible for postoperative increase in oxygen consumption? They are the catecholamines, both endogenous and exogenous, that happens from the operation. Is the systemic inflammatory response that we cause to the patient, both because of the cardiopulmonary bypass and of the operation as well. Fever can be a cause of increase in oxygen consumption. If the patient is not asleep or is suffering pain or anxiety, this is another reason. Spontaneous breathing is another reason, and sometimes enteral nutrition can cause that as well. Regarding the oxygen delivery to the tissues, that's the byproduct of cardiac output, the amount of hemoglobin. So if the patient is anemic following the operation, we need to sort that out. And of course, the oxygenation in the blood, the saturation in the blood. We show all this here. So there are a few special circumstances during the post-operative care, especially following Norwood 1 procedure, that the oxygen delivery is a situation where is affected by the QP-QS ratio as well, but then the equation becomes very complex. And also, after the Glenn shunt, we have to take into account the ratio of blood that goes into the upper part of the body that is connected to pulmonary artery compared to and then the rest of the blood that is still connected to the inferior vena cava. But I will stop with these complex equations now and try to move on. So when is the time to interfere when we find out that this status happens? Ideally, we should interfere before there is damage to the end organs because of the ischemic injury and the development of organ failure. How? There are many strategies, but at the moment there are no guidelines as well. So there are multiple interventions available. So trying to find out what to do, we use some advanced adjunctive monitoring modalities, trying to make a timely and accurate assessment of cardiovascular function and, and estimate the adequacy of tissue oxygenation. So in order to monitor our pharmacological intervention, we can use clinical indices of decreased cardiac output, but as you know, these are not neither specific nor sensitive, so we cannot make any clear decisions on that. We can use invasive and non-invasive cardiac output monitors in congenital heart disease surgery, but they have limited utility, and to date they have not been demonstrated to improve the outcome. We use the ultrasound evaluation of cardiac status and volume condition. We have the advantage to have the cardiology team always on our side, and they can give us great insight whether the patient the heart cardiac function is better or not, or the patient looks that needs volume. We use the NIRS monitor. NIRS stands for near infrared spectroscopy. It's a kind of evaluation of oxygenation on different parts of the body, either the brain or the renal area where this goes to the splanchnic circulation. And you can use mixed venous saturation as a good monitor for the relationship between oxygen supply and oxygen demand balance, and can be useful in patients with high risk for oxygen transport imbalances. And finally, we use serious blood lactate levels is an important monitor for inadequacy of tissue oxygenation, and that correlates with the outcome in infant congenital heart disease surgery. So we see here a picture from a 8-year-old boy who had a tetralogy of fallow repair, was taken to intensive therapy unit. On the top, we see the NIRS near it was put on the renal area. We see the mean arterial pressure. We see the bicarbonate levels and the lactate levels. A few hours later, these things started to go up and the bicarb started to go down, and the patient suffered here a cardiac arrest. And once this cardiac arrest was sorted, the things came back to normal. So this is a very useful monitor that can give us a few time to anticipate what is going on and how we should avoid that. And of course, we know that as the extraction, the patient, as we reach the critical level of DO2, the extraction ratio increases up to a point. So how do we proceed with that? We have to take things out of the way first, and it's good to have an initial checklist to see that we have adequate airway, or if the patient is still intubated, we have the correct tube in position regarding the size and patency of the tube. We have to make sure that we ventilate the patient suffers no pneumothorax, and we need to make sure that there is no pericardial tamponade or bleeding. These are not very easy to sort out all the time. We need to make sure that we don't have a pulmonary hypertensive crisis, no arrhythmias on the patient, and no residual lesion, and there are no electrolyte abnormalities. So the strategies that we follow to try to sort this problem out is once the previous things have been sorted out, is trying to optimize the preload, optimize the cardiac contractility, and reducing the afterload. Because if we reduce the afterload, that helps the heart operate better and push the blood forward and sort the problem. To optimize the preload, we need to determine whether in which position of the ventricle on pressure stroke volume the heart lies at the moment. So echocardiography is very useful on that. But if we use indices like the right atrial pressure or the left atrial pressure, they are not very helpful because they cannot tell us exactly where we are regarding volume status. That's why we have abandoned now putting LA lines. And we can always give a volume challenge either by pushing the liver of the child or giving a bolus fluid of 5-10 mL per kilo and see what hemodynamic effect that has. Ideally, if this is followed with an increase in blood pressure and a decrease in heart rate, that's a good case scenario. That means that the patient needed some more volume. Regarding optimizing contractility, we can use either calcium or catecholamines or phosphodiesterase 3 inhibitors like milrinone or calcium sensitizers like levosimendan. Again, from physiology, all these drugs are working by trying to liberate calcium from the endosarcoplasmatic reticulum to the cytoplasm. And then get that connected to troponin C and make make the muscles contract more effectively. So we use beta agonists to work through the beta receptors. They work by making the AMP, cyclic AMP, and then through the protein kinase A, they work to the sarcoplasmic reticulum to release calcium. The CAMP is degraded by the adenyl cyclase and by phosphodiesterase, and phosphodiesterase inhibitors like milrinone act exactly there. And then the calcium sensitizers like levosim and DAN, they act by facilitating the troponin C to connect the calcium. To manipulate afterload, we need drugs like glycerin trinitrate and sodium nitroprusside. They increase they manage to release the afterload of the left side heart. But we need to be cautious that we do not lower the blood pressure so that the coronary perfusion pressure does not go. We don't want to drop the diastolic pressure very much. Actually, sometimes instead of using instead of lowering the afterload, we try to increase the afterload using vasopressors like norepinephrine or vasopressin, and trying to make sure that we have adequate coronary pressure. Also, regarding the right of the heart, the right ventricle, we try to avoid to enter in the vicious cycle of low cardiac output system status when this causes pulmonary hypertension and this causes right ventricular failure, and then this completes the cycle and we have lower cardiac output situation. So we use pulmonary vasodilators like inhaled nitric oxide, or we can use sildenafil when we try to get rid of nitric oxide, or prostaglandins. These work by the cyclic GMP that actually tries to lower the intracalcium calcium and thus help the tissues relax better and lower the pulmonary pressure. So from the left side of the heart, we try to increase the calcium, and from the right side of the heart, trying to increase the calcium. Very easy. So the role of positive pressure ventilation in the low cardiac output system, is it a drug? Yes, if you are planning to use inhaled NO. And actually, we can see that if we manage to the PCO2, the carbon dioxide, so we go to higher levels of pH, that's easier then to control the pulmonary vascular resistance by increasing the PO2, the oxygen, the partial pressure of oxygen in the blood. And actually, we have seen that there is an area where the pulmonary vascular resistance is lower, and thus near FRC, and thus is the rationale for using high-frequency ventilation sometimes if it is tolerated by the patient to lower the pulmonary vascular resistance. Other pharmacologic support that we might use, we use steroids, especially before we go on bypass, we tend to use steroids. There is no evidence that it offers something to the patient, and actually there is evidence that it might cause an infection to the patient. Thyroid hormone also has the rationale that it might increase the cardiac output, has no benefit to the patient. Calcium is a short-acting inotrope, let's say, that increases the cardiac output for a short period of time, but again, if we give too much calcium, that may have a result cell death. Sodium bicarbonate, we try to correct the pH disturbances, and this seems to be beneficial for the moment, for a short period of time as well, but in the end, it causes more intracellular acidosis. Nasiritide is a BNP analog that helps regulate the fluid of the body. Hasn't seemed to cause any favorable effect to the low cardiac output status. And also the same goes for phenol-pam. What makes significant difference, think people, comes from this Primacorp study that came about 20 years ago and used milrinone in order to prophylactically to try to avoid the low cardiac output status. And it was used in 238 patients in 3 groups. One group received placebo, the other group received low-dose milrinone, and the other group received high-dose milrinone. It was the researchers noticed a reduction in low cardiac output status by 50% in the high dose. We tend not to use the high dose because there is a lot of concern regarding the metabolism of milrinone in the neonatal patients, and also because there are concerns regarding the vasodilation. So we tend to use an average dose of 0.5 micrograms per kilo per minute for the patients. After that, a few more studies came regarding milrinone, and after almost 15 years, there was a study from the Cochrane database trying to see whether these studies also actually have a benefit to the patient. And what we know so far is that there is insufficient evidence that milrinone, which is the inotrope we currently use, is of any significant benefit to the patient. So we thought, let's go to another inotrope, and we try to avoid the catecholamines if possible. So that is why we try to use either milrinone or levosimendan. So there were a few studies coming out with use of levosimendan, which is far more expensive than milrinone. And then a few years later, the systematic review of the use of levosimendan said that there is insufficient evidence that is beneficial as well. So we thought, okay, let's go back to catecholamines and compare the milrinone and with dobutamine this time. And then again, it came out that no one is better than the other. And actually, we don't need whether we do anything to the patients as well. So after we failed to show any clear effect with the inotropes, we said, let's see what the people who deal with the case every day do. There was a study, actually there was a European survey a few years ago. It involved, there was a questionnaire that sent to 125 centers, almost 90 received. Most of the people use almost 6 drugs, although there are many strategies to do. Most of the people use either milrinone, dopamine, epinephrine, dobutamine, and levosimendan. That's about 86% of the drugs used. Milrinone was reported to be used at about 70%, and all the other regimens in significantly lower amounts. So a few years later, another study came asking the Pediatric Cardiac Intensive Care Society which is their practice almost 15 years after the previous one. And again, almost 50% of the people responded. A lot of them came from the United States. Almost 97% of them use milrinone. Some use adrenaline. Some use dopamine or dobutamine. Almost half of them use steroids, which seems to be wrong. Some use vasopressin. And most of people rely on mixed venous oxygen saturation, but with intermittent specimens and not with continuous. This is very low. Almost 1 in 4 people use the NIRS, the near-infrared spectroscopy. Almost 1 in 2 uses the echocardiography. And it seems most of the people tend to add or increase milrinone if they face the syndrome. 1 in 3 adds adrenaline, and 1 in 6 adds dopamine. So people who still tend to believe that milrinone, if any inotrope can do the job, is the drug, and they think that it's the different levels of milrinone that can have significant change to clinical outcomes. So the people from Canada who use this, they try to make an assay to measure the plasma levels of the milrinone, and they say that if they manage that, they will be able to change or adjust the dose of milrinone and have better outcomes. So this is a pilot study, and it says that monitoring milrinone levels is visible, and milrinone levels are related to clinical important outcomes. So larger studies are about to follow. Other non-pharmacological measurements that one can use to sort out this problem is keep the temperature of the patient low, try to avoid increase in oxygen consumption, leave the sternum open. This is something that sometimes we might use, and if anything fails, we need to think about mechanical support to the patient. So very often I find myself, with the decibels as well, sitting in this table with Al Capone, saying everything went well. It is a teamwork. The patient has to, we have done everything well, but it is time for individual achievement. And we are part of the team. I believe you know what happens next. In conclusion, the low cardiac output syndrome is a frequent condition with significant contribution to morbidity and mortality. The key to mitigating to low cardiac output syndrome in the post-operative period is early recognition and timely intervention. Thank you very much for your attention.